Om Swastiastu, Assalamualaikum warahmatullahi wabarakatuh, Shalom Namo Buddhaya. Greeting of Virtu, my peace be upon us all. Good morning everyone. As your master ceremonial, let me introduce myself. My name is Dr. Ega. I'm a doctor at Emergency Department of Udayana University Hospital. So, welcome to Udayana University Hospital on this special event, general lecture, and hospital tour from President of Yamaguchi University. First of all, a very warm welcome to the Honorable Professor Yukio Tanizawa, MD, Ph.D., as the President of Yamaguchi University, Professor Tetsuji Umaba as Professor of Faculty of Medicine, Faculty of Economic, Hiroyuki Tanaka as Director, International Exchange Division, Mashiro Ueda as International Planning Section, International Exchange Division. And a very special welcome to respected Dean of Faculty of Medicine, Udayana University, Profesor Dr. Komang Januarta Putra Pinati, MKes, the Director of Udayana University Hospital, Profesor Dr. Dewa Putu Gede, Purwo Samatra SPN, Konsulen, the Moderator, Profesor Dr. Ketut Swastika, SPPD, KEMD. And on the list, the Honorable I respect the most to all the invited guests, Professor, Doctor, internist, resident, co-assistant, and all health department and staff of Udayana University and Udayana University Hospital. Thank you for your time. First of all, let us over gratitude for the presence of God who gave us His mercy and guidance so we can attend together for this special event. And we will sing the national anthem of Japan and Indonesia. Please, all the present are expected to stand.
Kimi
representant are welcome to sit back again. Thank you. Okay, the next is a welcome speech that we will be delivered by Mr. Professor Dr. Dewa Putu Gede Purwa Sumatra, SPN Consultant as a President Director of Udayana University Hospital. Please.
Good morning. Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Salam Namo Buddhaya. Mina sama Ohayo gozaimasu. Good morning everyone and very warm welcome to Honorable Professor Yukio Tanizawa, MD, Ph.D, President of Yamaguchi Universitas. Professor Tetsuji Umaba, Professor Faculty of Economics. Hiroyuki Tanaka, Director International Exchange Division. Masahiro Ueda, International Planning Section, International. And very special welcome to Dean of Faculty Medicine Udayana University, Professor Dr. Komang Januarta Putra Pinati, Professor Dr. Ketut Swastika, SPWD KMD, as a moderator to this meeting, and all of the audience. Today we are very honored to have the Professor of Yamaguchi University and the state one in lecture for the general lecture and hospital tour to the Udayana University Hospital. We really hope the opportunity can become a bridge and establish cooperative to improve human resources and development education for students Udayana University, and helpful to the President Yamaguchi University to and this team visit and help expand Udayana University partnership, which include Udayana University Hospital. We apologize on any shortcoming and inconvenience to my occur during the event, and the deep apologies. Thank you. Makato ni arigato gozaimasu. Om Santi 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 Om. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Professor. And the next is a welcome speech that will be delivered by Mr. Professor Dr. Komang Januarta Putra Pinatih, MKes. As a Dean of Faculty of Medicine, Udayana University, please.
Yeah, thank you. Good morning, everybody. To the Honorable Professor Yukio Tanizawa, MD, Ph.D, President of Yamaguchi University, along with all delegates from Yamaguchi University, to the respected Professor Purwa Samatra, Director of Udayana University Academic Hospital, Professor Dr. Ketut Swastika as the moderator of this special lecture for today, and also all of the respected guests, ladies and gentlemen. This is a great pleasure for all of us that we can gather together here today to attend this special guest lecture from Professor Yukio Tanizawa. As a Dean, on behalf of Faculty of Medicine, Udayana University, we would like to welcome Professor Tanizawa with all delegates from Yamaguchi University, and also our highest appreciation for your kindness to visit us here, to visit Udayana University, also to visit Udayana University Academic Hospital. But it's unfortunately you will not visit our Faculty of Medicine because it's quite far away from here. It's about 35 kilometers from here, our main campus of Faculty of Medicine. But I hope in the future, if you come again to Bali, you can come to our Faculty of Medicine. The visit of delegates from Yamaguchi University, I think, is a great opportunity for us, yeah, to improve, to strengthen our capacity, because this hospital, Udayana University Hospital, is a quite brand new hospital. I think it's officially open for operational about 5 years ago. We still need a lot of efforts to develop, yeah. So collaboration with other institutions, either it's a national and also international institution, is we need it, yeah, to improve our capacity of this hospital. Because this is our academic proof, the quality not for all for service, but also the quality of our education in this hospital. So I think the visit from Yamaguchi University is a great opportunity for us, for the hospital, and also for me in the Faculty of Medicine, to discuss and also to arrange any collaborative project, either in the academic and also in research field. So in the future, we can improve our capacity and also our quality in academic and also in the service. So once again, we would like to thank Professor Yukio Tanizawa, yeah, and also from all the delegates from Yamaguchi University. And once again, maybe in the afternoon, I think we will have a detailed discussion with several other faculties, to discuss about any possible collaboration between Yamaguchi University and several faculties from the Udayana University. So I think we hope we will, in the future, we will have a lot of collaborative project we can conduct together. Thank you, Professor Tanizawa, and also from all of the guests attending this lecture today. And I finish this speech by Om Santi 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 Om. Wassalamualaikum warahmatullahi wabarakatuh. Selamat pagi.
Thank you, Professor. Now is the photo session. Please just stand at the chair for all the President, Director of Udayana University Hospital, Dean of Faculty Medicine. Just di sini aja. Oh ya. President Yamaguchi University and all the delegates and the moderator. Please stand. And all the participants, please stand. Thank you. Thank you. Please sit back again. Okay, so now before we start the essence of this event, let me introduce you the moderator of the general lecture today, Mr. Professor Dr. Ketut Suastina, SPPD, KGE, MD. Swastika. I'm sorry, Mr. Professor Dr. Ketut Suastika, SPPD, KE, MD. He is an diabetic expert in Udayana University. And the speaker of general lecture today will be the President of Yamaguchi University, Mr. Professor Yukio Tanizawa, MD, Ph.D. Please, Professor, time and place are welcome.
Good morning, everyone. I'm very happy to be here, and it is a great honor for me because this meeting is not very important for Udayana University in general, because this meeting also become memorable for myself. Because in 30 years ago, 30 tahun yang lalu, in 1992, I was attending a staff exchange in Yamaguchi University in the Metro President Department. In that time, I'm under Professor Kaneko and also Professor Kaku. And in that time also, I know his name from the the name staff. Because in that time, he still become postdoctoral program in state in Washington University. So, very happy once again, and also personally and on behalf of Udayana University, we express our thanks, appreciation, and also welcome to our university, and also all staff of Yamaguchi University. And finally, we are very happy because we have a similar fields, especially in diabetes. And Professor Tanizawa, as expert of diabetes especially, will talk about the recent knowledge, scientific on diabetes, especially in the clinical and also the research. We know that the research of diabetes in Japan is far developed, compared in our countries. And so many research in Japan have already adopted and can be used as a clinical using in our country. So very happy once again, and then please, Professor Tanizawa, time is yours.
Thank you very much for a very kind introduction. As he told me, we are very deep connection since 16 years.
30.
Oh, 3
yes,
okay.
30 tahun. Yeah.
Yeah. At that time, I was in United States as a postdoc, so I actually couldn't meet you in the Yamaguchi University. But anyway, thank you very much for giving me this opportunity, and this is a great honor to me to be here in Udayana University. Let me talk about diabetes. My major is diabetes. And the first slides show the 4 seasons in the campus of Yamaguchi University. As you know, Japan has very clear 4 seasons. In the spring season, we have a cherry blossom in our campus. This is very beautiful. And in the summertime, there is a lot of sunshine. And the temperature is even higher than here in Bali, very hot. Actually, this summer, the temperature goes up above 35 degrees. That's crazy. And there are a lot of greens here. And in autumns, we have a lot of red and yellow leaves inside our campus. And in winter, we have snow in the campus. So our university have very beautiful campus. So please visit us to our country and to our campus, Yamaguchi University. And firstly, let me introduce about myself. I'm Yukio Tanizawa, And I graduated from Yamaguchi University 1983, almost more than 40 years, about 40 years ago. After the clinical training and research experience as a graduate student, as he introduced me, I went to Washington University and joined the Division of Metabolism under the guidance of Professor Alan Palmat from 1990 to 1993. And then I returned to Yamaguchi and fortunately get a position of professor in 2002. And I was appointed to the position of Dean and Director of the Faculty of Medicine, Graduate School of Medicine, and then assumed to the role of Vice President, Trustee Vice President, and eventually having been appointed as President of Yamaguchi University in 2022, April last year. My major is internal medicine, especially endocrinology and metabolism, and I am a certified diabetologist and endocrinologist. I serve as the executive director of the Japan Diabetes Society. And my research primary interest focus lies in the molecular mechanism of causing pancreatic beta cell failure in diabetes. I was honored with Hagen Awards from the Japan Diabetes Society last year. The last of my talk, I will shortly introduce my own research. Okay, I think, of course, insulin is a key molecule of diabetes, as you know. And also, I believe that insulin has led science and medicine. I'll tell you the reason. And insulin was discovered 102 years ago, 1921, by Banting and Best in Toronto University in Canada. In summer of the 1921, the two investigators, actually Banting was a student of medical school at that time at Toronto University, was succeeded in isolating, purifying the insulin from the pancreas. At that time, people know that the key molecule probably in the pancreas, because one removed the pancreas from the animals, it's become diabetes. So they tried to isolate insulin and was successful in 1991. And surprisingly, the insulin was manufactured purified from a bovine pancreas or the pig pancreas. This large amount of pancreata produce a single vial of insulin. But this is a great discovery. And in 1922, actually, 1922, the insulin became available commercially. And this changed the history of patients of diabetes. Before 1992, the patient with type 1 diabetes, usually children, has to die after 1 or 2 years after diagnosis because he cannot produce insulin at all. So they develop ketoacidosis and going to die. But when he injected insulin, they come back to the normal child. And another miracle is here in this girl, Elizabeth Hughes. At the age of 11, she developed type 1 diabetes. In 1922, at the age of 15, she became one of the first patients to receive insulin therapy. She continued insulin treatment for the next 58 years. And she later married William T. Gossett, who would become vice president at Ford, the car company. And together they had 3 children. She passed away at the age of 73 due to pneumonia. So that means this girl completed her lifetime as a people without diabetes. So insulin makes miracle to her and other patients with diabetes. And sorry, maybe 5 is very heavy. And this is Banting. And in 1923, just 2 years after the discovery of insulin, he was awarded Nobel Prize. And that is really worthwhile because of the rescues a lot of patients' life. And insulin is a molecule-led medicine and science, I told you previously, because the Frederick Sanger, he discovered a way to sequence the peptide and then sequence the nucleotide gene. So the first peptide, the first proteins to be sequenced was insulin, and the first gene to be discovered was insulin. And then Dr. Hodgkin, she determined the 3-dimensional structure of insulin by X-ray crystallography. And this is the first of the 3-dimensional structure was determined for the protein. And she was also awarded Nobel Prize. Actually, the Sanger, as you know, received Nobel Prize twice, once for the protein sequencing and the other for the DNA sequencing. And Rosalind Yarrow accomplished a remarkable achievement. She developed a way of measuring very small amount of materials like insulin in the blood. She developed a way of radioimmunoassay. That's made a great advance in the endocrinology. And she also received insulin. In that way, the insulin led the science and medicine. Let me change the topic to the diabetes itself. Okay, the diabetes is a pandemic in the world. And in Japan and also in Indonesia, 10 to 20 million people suffered from diabetes. Actually, in Japan, 11 million people suffered from diabetes. And the number of patients of diabetes is increasing worldwide. Okay, in the world, 2021, there are 537 million patients in the world. But this increased 46% by the year of 2045. And in Western Pacific region, here in Japan and Indonesia and China, Australia, the number of patients increased 27% by 2045. And actually, Indonesia is the top 5 of the number of patients of diabetes Actually, Japan is the ninth at this moment, 2021. But in 2045, Indonesia is still the top 5, and Japan's lose this way because the number of population is decreasing at this time in Japan, so that the patient number is decreasing. But still, diabetes is a big problem at this time, and especially Indonesia is top 5. And China, India, Pakistan, United States, Brazil, these countries, there are very many patients. Okay. In Japan, since 1955 to 2019, the patients of diabetes increased 50-fold. And now, I told you before, the 11 million people suffered from diabetes. And why this increase occurred? Because of less physical activity, more calorie intake, and more fat intake, and more obesity. This is also the case in Indonesia, I think. And also, in Japan, there are more and more aged people. And in 1955, only 5% of the general population is above 65 years old. But nowadays, 2021, about 28.9% of people, about 1/3 of the people is above 65, and this number is still increasing because aged people have less potency to insulin secretion from pancreas, and insulin resistance is higher because of less muscle, and the muscle is one of the largest insulin-sensitive organ. So the aging is a very important factor for the diabetes. And what is diabetes again? The diabetes is characterized by the chronic hyperglycemia, and the blood sugar is around 100 milligram per dl, and caused by insufficient insulin action, total insulin action. Insulin action is the sum of insulin, secreted insulin, and its action. Insulin secretion deficiency and also the insulin resistance cause total insufficiency insulin action. That's cause diabetes. And the problem is diabetes cause many diabetes chronic complications. And the diagnosis of diabetes is relatively very simple. If you measure the blood sugar, you can make a diagnosis. When your blood glucose is more than 126 milligram per dl before breakfast, after more than 8 hours fasting, you are very likely to have diabetes. And at any time, you measure, when you measure blood glucose and the blood glucose is more than 200 milligram, that's also very likely to be diabetes. And the standard method is the oral glucose tolerance test. And you ingest 75 grams of glucose and measure the blood sugar 2 hours later. And if the value is again more than 200 milligrams, you are very likely to be diabetes. Why we set this diagnostic criteria? This is the threshold of diabetic complications, especially the retinopathy. As you can see here, in Asians, like Pima Indians and Caucasians, this is the risk of diabetic retinopathy. This rises quite rapidly. Around the fasting blood glucose is 126. And hemoglobin A1C corresponds to about 6.5%. This is the reason that the diagnostic criteria is set. And this is the classification of diabetes mellitus. As you know, the diabetes is classified largely into 4 types. And type 1 diabetes, I told at the beginning, usually occur in children and young adults. And the pancreatic beta cell stop secreting insulin by autoimmune destruction or by unknown reasons. The pancreatic beta cells destroyed. So without insulin, they are lethal. And type 2 diabetes, more than 90% of the diabetes patients have type 2 diabetes. Actually, type 2 diabetes is very heterogeneous. The one patient is majorly insulin secretory defect, and the other one is majorly insulin resistance. Mostly the combination of 2. There are other types of diabetes which is the reason is specifically identified. Like if you remove the pancreas because of the pancreatic cancer or chronic pancreatitis, you will become diabetes like that. And some of the rare case, the specific gene is destroyed, like insulin gene or insulin receptor gene, and some other genes cause diabetes. And gestational diabetes is another category. They develop diabetes or abnormal glucose tolerance during the pregnancy. This is clinically very important because that affects a lot on children and also mother. So we have to care especially for those with gestational diabetes. And this is the blood sugar of myself. We can continuously monitor blood sugar nowadays without a lot of effort. Actually, I showed here just the result of 4 continuous days. As you can see, my blood sugar is strictly around 100 milligram per dl. So don't worry, I'm not diabetes myself. So as you can see here, the blood sugar is very strictly controlled in a very small range. That is because when you ingest food, the pancreas secretes insulin very rapidly and with very good timing. That prevents the rise of blood sugar. And if the insulin secretion is less or the retarded, the blood sugar starts to go. And the insulin is the only hormone that can lower the good blood glucose levels. There are several hormones that increase the blood glucose levels because glucose is very important energy. And if the glucose is very low, you can lose your life. So that there is the multiple hormones to go up, rising in glucose, but there is only insulin that lowers the blood glucose. And as I told you, the insulin is secreted from the beta cell inside the pancreas. In pancreas, there is very specific small tissues called islet of Langerhans. This is the endocrine tissues, and most of this island is composed of beta cell producing insulin. And when insulin is released to the bloodstream, they goes whole bodies. Every cells in our body have insulin receptor, and every cell needs insulin actions. And especially metabolically important organs are fats and the liver and the skeletal muscles. And these are the major insulin acting organs. And if the insulin act normally, they will become diabetes. And adipose tissue is very important for the insulin action, insulin resistance. That's the reason you become obese, you will become diabetes. As shown here, in the adipose tissue, these are fats, each fat cells. And in the inside, among the fat cells, there is several immunocytes. And if you weight gains and more fat cells, the immune cells accumulate more, and they start to secrete some cytokines and called adipokines. This causes insulin resistance to acting in the body. That's one of the reasons that the obesity causes diabetes. And another important issue is our Japanese and maybe Indonesians people's diabetes is quite different from diabetes in the Caucasians. The Caucasians are the hunting culture, and they eat traditionally, from long time ago, they eat more fat, and they require more insulin, so that they developed to secrete more insulin. So that in the Caucasians, the overweight is, for instance, normal. And if they become real obese, they still may not develop diabetes. The average BMI of the diabetes patients in the Caucasians is about 30, or maybe more than 30. But in Japan, the average BMI of diabetes patients is somewhere around 25. So that is not real obese, but just maybe overweight. That is sufficient to develop insulin resistance and diabetes, because Japanese and Asian people is farming culture, and usually they do not require large amount of insulin. But the lifestyle changed a lot. That make diabetes in a higher ratio. And another important issue is type 2 diabetes is progressing. And for type 2 diabetes, the insulin deficiency and insulin resistance both is very important. If you gain more insulin resistance, the pancreas secretes more insulin, so that at the initial period, the blood sugar won't go up. But if the insulin resistance become more, and the beta cell cannot compensate for the increased insulin secretions, at that time, the blood sugar starts to go up. And once blood sugar goes up, the insulin beta cells is more suffered from the dysfunction, so that the blood sugar gradually goes up further, and usually often require some pharmacological therapy. So that's the reason diabetes treatment start very early. Okay, why is diabetes a problem? And usually, if you have mild or moderate hyperglycemia, like 200 milligram per diet, there is no symptoms at all, and you even don't know you have diabetes unless you check by health checkup. But if blood sugar goes up quite higher, like about 500 milligram, the acute symptoms appears. That is, for instance, thirst, polyuria or polydipsia, more urine, and weight loss. And if the blood sugar goes up more higher, that causes diabetic ketoacidosis, and sometimes hyperosmolar hyperglycemic syndrome. The diabetes ketoacidosis is the extreme deficiency of insulin, so that type 1 patients often develop ketoacidosis. And hyperosmolar hyperglycemic syndrome usually occur in the elder type 2 diabetes patients. These are the very extreme case of the acute symptom. And the chronic complications are more important. Although the moderate hyperglycemia causes no symptoms at that time, but after 10, 20 years, they cause several complications, like diabetic retinopathy. This is a leading cause of blindness by disease, and diabetic nephropathy. This causes renal failure and require hemodialysis, and diabetic neuropathy. These are called diabetic microvascular complications. This is quite specific for diabetes. The other diseases does not cause this type of complications. But other important diabetes complication is atherosclerotic macrovascular complications, like myocardial infarction, stroke, or peripheral vascular diseases. And these are associated with the other conditions, like dyslipidemia, hypertension, and obesity. But so this is not diabetes specific, but if you have diabetes, the risk is much more higher than those without diabetes. So that you have to treat your diabetes. Okay, this is the cause of hemodialysis in Japan. And the introduction to hemodialysis is the diabetes nephropathy is number one since 1995. And nowadays, very fortunately, the number is tend to decrease because of the awareness of the diabetes complication is become higher and higher. That make this decrease, but still a lot higher than other reasons. So the most of about 40% of the patients who newly require hemodialysis is diabetic nephropathy. Probably this is also the case in here in Indonesia. And treatment of diabetes. The lifestyle modification, diet and exercise are basically important. But if this is not sufficient, the pharmacotherapy is often necessary. And in past 10 years, there are a lot of diabetes drugs developed. Okay. When I was a doctor about 40 years ago, the sulfonylurea and insulin was the only drug for the diabetes treatment. And there was biguanide, but rarely used before 1990. At the time, UK PDS study showed the benefits of biguanide. But in recent 10 years, there are many kinds of drugs developed. And some are the insulin secretion stimulating, and the others are not stimulating. Rather, the insulin sensitized or the reduce insulin resistance. And insulin also very rapidly progresses. In the past, bovine or pig insulin are used, but after 1990s, the human recombinant insulin became available. And recently, the insulin analog, some of the amino acid is replaced artificially so that the character of insulin will become more suitable for the treatment. Some insulin are short-acting or rapid-acting. This is very good to control the blood glucose just after meal. And for the sustaining effect, the long-acting insulin usually lasts more than 24 hours, but probably in 1 year or two, the insulin that lasts a week will be in the market. And another injection drugs is incretin-based drugs. This is GLP-1 receptor agonist and the GLP-1 GIP dual agonist. I will tell you about this later. And because of there are a lot of choice for the treatment, there must be some guidance for the choice of drugs. And this recently, Japan Diabetes Society make this algorithm, suggest this algorithm. The most important thing is at the first beginning, if whether you require insulin treatment absolutely or not. For type 1 patient, we have to treat with insulin, otherwise the patient will die shortly. And if not insulin dependent, we can have a choice. Firstly, for each patient, we have to set the goal of usually the hemoglobin A1C is the indicator. And then if this type 2 patient is insulin deficiently, the insulin deficiency is a major cause, or the insulin resistance is a major. The easiest thing to distinguish these two is the patient is obese or not obese. In this case, obese is not markedly obese, like BMI 25, that is obese in Asian people, as I told you before. So, because of, based on these patient's characters, we can use the suitable drugs. And then after starting the treatment, we have to examine whether the patient meet the treatment goal or not, and maybe add more drugs or exchange the drugs to the other one. And another thing is very recently, in addition to the lower the glucose, some of the drugs have additional benefit. Like some drugs prevent the diabetic kidney progression, and some drugs prevent heart failure, and some drugs prevent the atherosclerosis and myocardial infarction or strokes. If the patient has very high risk of these conditions, we have to choose the drugs suitable for these conditions. And some of the newly developed drugs, like incretin-based drugs and SGLT2 inhibitor, I will introduce you shortly. And incretins are the hormones secreted from intestine in response to food ingestion. And incretin is namely GLP-1 and the GIP. These are secreted from intestine. They act to pancreas beta cells to potentiate insulin secretion glucose dependently. If your blood glucose is already low, the incretin cannot act at all. But if your blood glucose is higher, the incretin stimulate insulin secretion. This is very beneficial characteristic because this drug is rarely cause hypoglycemia. Hypoglycemia is the most important risk associated with diabetes treatment. And the other action is the action from stomach and the intestines. They slow the intestinal movement and absorption that prevent to rise the glucose after food ingestions. And also, more importantly, the GLP-1 and GIP suppress the appetite. That help reduce your weight. And GLP-1 and GIP, once secreted in the bloodstream, they will degrade very rapidly in usually 1 or 2 minutes. So if you have DPP-4 inhibitor, this can be a drug as a diabetes treatment. Actually, DPP-4 inhibitor as an oral agent and very often used in Japan. And this is one of the GLP-1 receptor agonist, semaglutide. This is very strong actions, like semaglutide. This is the effect on the Japanese patient. Hemoglobin A1C decreased more than 2%. This is a very good response because most of the oral agents can reduce the hemoglobin A1C only 0.7% or at most 0.8%. And GLP-1 semaglutide or GLP-1 receptor agonist can decrease the blood hemoglobin A1C more than 2%. And also, as I told you before, the semaglutide reduce the body weight, and usually in a higher dose, about more than 3 kilogram loss on average for the patients. But more strikingly, very recently, the GLP-1 and the GIP dual agonist is on the market. This effect is very strong and surprising. And the basal weight is just 78.3 kilogram. And these are Japanese patients. In a higher dose, they use average 10 kilograms. That makes the 78 kilogram patients become 68 kilogram. So some of this kind of drug is approved as a treatment drug for obesity. And another benefit of GLP-1 receptor agonist is they can prevent myocardial infarction or maybe stroke in 2-3 years treatment. This cannot be happened just controlling blood sugars. So this is very striking character of GLP-1 incretin drugs, GLP-1 receptor agonist. And GLP-1 receptor agonist also prevent the kidney disease worsening. And the other drug is SGLT2 inhibitors. SGLT2 means sodium glucose transporter. And usually from the blood, the glucose is filtrated to the renal tubules freely. But most of the glucose is reabsorbed and come back to the blood. So your urine does not contain any glucose in the normal conditions. But in the diabetic patients, because of the blood glucose is higher and very large amount of glucose is filtration out, so that the urine glucose become positive. And SGLT2 is usually act here to reabsorb glucose. And the SGLT2 inhibitors they prevent or inhibit the glucose reabsorption, so that the patient with diabetes who receives GLP-1, SGLT2 inhibitors lose more glucose in the urine. And this is not ecologically right, because the diabetic patients lose their glucose into the urine, and that decrease the blood sugar. But very, very surprisingly, this drug prevents the heart attack, cardiovascular death, and heart failure. So this drug also has additional benefit in addition to the blood glucose control. So SGLT2 inhibitor has become more and more commonly used in Japan and worldwide. SGLT2 inhibitors also prevent worsening of blood glucose. So that because there is a lot of kinds of drugs for the diabetes treatment, we have to understand the character of each drugs and give the patient most suitable drugs. That is very important. And another advancement is the device. As I told you at the beginning, we can monitor the glucose, blood glucose continuously up to 14 days in a single device. You put this kind of small device on your arm, and if you bring here the detector, you can use the smartphone as a detector. You can actually real time, you can monitor blood glucose real time, and the memory collect the blood glucose and accumulate for up to 14 days. So that blood glucose in the 40 days, how often the blood glucose goes higher than, for instance, here, above 180 milligram, and become lower than 70 milligram. And usually the goal is the target range 70 to 180 milligram. The 70% is the goal. And this is actually my patient of type 1 diabetes. She is very good control. And the target range is a little bit lower than the target goal, 70%, but the very low frequency of hypoglycemia, just 14 minutes below 5 milligram in 2 weeks, so that we can really actually monitor how far the patient blood glucose are, or how low the patient blood glucose are. This makes very blood glucose control easier. Then we can adjust the dose of the drugs very in good time. And another advancement is the glucose infusion pump. This is very good for the type 1 diabetes patients. This pump is programmable, so the patient's insulin secretion character, you can program how the insulin is injected under the skin subcutaneously. And once you connect this continuous glucose monitoring and this kind of pump, here is the artificial pancreas. And this is started to available for the clinical use. This makes the diabetes for the type 1 diabetes patients controlled very easily by preventing hypoglycemia. The problem is the cost. So that in this way, the treatment of diabetes is advancing very rapidly. And lastly, very shortly, I'd like to present our research activities. I believe that the investigation of rare disease is very important. This discloses the common pathways. In the past more than 20 years, I am working on the very rare disease, Wolfram syndrome. In this patient, diabetes developed 10 years or earlier. And like type 1 diabetes, insulin secretion is almost completely lost. And in the patients, the beta cell, insulin secreting cell, disappears. In addition to diabetes, in these patients, usually develop blindness because of optic atrophy. And there is a lot of other symptoms, so that the quality of life is very impaired. And this usually genetic disorders, autosomally inherited. And very fortunately, we can successfully identify the gene causing this rare disease about 20 years ago by the collaborations of the other doctors and the patient's family. The three big Japanese family was very helpful to identify the gene causing this. And the structure of the gene product is like this. A very large protein resides in the endoplasmic reticulum. And this, the gene or gene product was totally unknown when we discovered this. And the function is, of course, totally unknown. For next more than 20 years, we are doing working very hard to identify the role of this molecule on the insulin secretions. And we created the knockout mouse of this gene. In the knockout mouse, after 38 weeks of age, this is the adult, the insulin secreting beta cells shown in green here is almost completely lost, and the blood glucose goes up very high. Under these conditions, the beta cells have a lot of signs of a lot of stress inside the cells. And this stress is caused by the loss of this molecule and suffered from the beta cells are very weak for the resistance to the stress. Because although the insulin secreting cells are almost completely lost, but the endocrine origin cells are still over there. When we stained for the endocrine precursor cells, the cells are already still there. They, for some reason, stop making insulin and secreting insulin. Because of, we call this phenomenon the de-differentiate. The cellular stress causes the differentiation. Okay, at the first beginning, because of WFS1 gene deficiency, the cell causes cellular stress, and the beta cells dies because of apoptosis. But more importantly, the cellular stress without this molecule cause the differentiation and stop producing insulin. And sometimes they become alpha cells to secrete glucagon. And this is the case in the a very rare disease, the same phenomenon occurs in patients with type 2 diabetes. And this is the result of investigation for the type 2 patients. Because of the, we do not have enough time. Here, again, in the type 2 diabetes patients, beta cells in the islet decrease. And on the other side, the alpha cells increase. This is because of the differentiation. The same phenomenon occurs here in patients with type 2 diabetes. So, the type 2 diabetes, for the development, a lot of genetic factors is working on that. And WFS1 deficiency is one of the cause of the type 2 diabetes. If completely you lose the WFS1 gene, that makes Wolfram syndrome very rare inherited disease. But the function of this molecule, the mildly impaired, that gives the risk of type 2 diabetes. So that WFS1 gene is one of the diabetes gene. And nowadays, there are more than 100 genes are known to be involved in the development of type 2 diabetes. And in the type 2 diabetes, common diseases like type 2 diabetes, very many genes variants are working there. Each of them very small effect. But in the rare disease like Wolfram syndrome, very single gene working have very strong effect. But studying rare disease reveals the common pathways. This is, I think, is an example of Wolfram syndrome research. So, our goal of diabetes treatment is by preventing the chronic complications of diabetes mellitus and achievement of same lifetime and quality of life as people like people without diabetes for the type 2 diabetes patients. But at the same time, glycemic control, blood pressure control, lipids control are very important. And also, so the investigation elucidating the pathophysiology, molecular mechanism of diabetes is very important, I believe. So thank you very much for your attention.
Thank you very much, Prof. Tanizawa, for your presentation. I think very interesting one. He talked about on I think the basic concept of the diabetes and finally the advanced research, especially in the rare disease. It's very interesting that you had already also presented in Q2 last month. Yeah. Okay. Maybe any question from the audience? Please, Dr. Indraguna.
Thank you, Prof, for the...
Prof. Tanizawa. Prof. Tanizawa, please, you can stay.
Oh, yeah.
Thank you, Prof. Swastika. Good morning, Prof. I'm Udayana from the Nutrition Department at this university. I have two questions because I'm working in the anti-aging medicine, one of our icons in Udayana University, and so many studies we do in animal studies about diabetes that we can treat it. That is my question since a long ago, because so far we know that diabetes is untreated but controlled illness. But in a study run by our students, they said that the beta cell can be recovered when we something like that. So it means like those diabetic can be treated well. So that is my question. Is that possible? The first.
Yeah.
And the second, we talk about the semaglutide, the GLP-1 antagonist. We use it as well for people with obesity. So looking at the side effect that the death because of or vascular disease is not reduced. So how safe is it for the people with obesity, with or without diabetes, to be treated as a GLP antagonist? Thank you.
Thank you very much for the question. The first question is very critical for us. We usually says the control of diabetes, but we have to cure diabetes, and there is still a long way to go to cure diabetes. But I believe that we are very slowly approaching to that. And for instance, GLP-1 receptor agonist is one of the possibilities that can reduce the reductions of beta cell number in the patient with diabetes. And otherwise, that is not completely cure the diabetes, but it is possible to at least stop the progression of the disease. And as I showed you in the last presentation, last of the presentations, some of the beta cell is not lost. The cells are still there, so we can revive there to secrete insulin. That can be the possibility of the diabetes cure, but we need more and more investigation for that. The second issue, the GLP-1 receptor agonist and the GLP-1 receptor GIP dual agonist is very promising drugs. And as I told you, there is approved for the treatment of diabetes in the United States and Japan and other countries. And how safe it is. But so far, it seems to be safe. At least we have more than several years experience for the treating type 2 diabetes patients. There is some GI symptoms like nausea or sometimes vomit or diarrhea, but otherwise it seems to be very safe. But for the obesity treatment, a lot higher dose is required. In that case, we are not very sure the long-term safety of that drug. We have to be very careful. Thank you very much.
Maybe only addition for how the diabetes can be return or recover, mostly impossible. Because both in type 1, type 1, and also type 2, we call the progressive, chronic progressive. And except in the few months, we have already known namely honeymoon periods in type 1, or maybe in type 2, can be returned to the normal. That means without medications, we call the remission. But almost both honeymoon too strong. Both honeymoon periods and also a remission in type 2 diabetes, but only run is not too long. Sometimes only 3 months or 6 months, or maybe only 1 year. And then after that, the disease will be run more progressive again. Yeah. Okay, thank you. Any other question from other participants? Okay, Mr. Dean, a new professor, congratulations.
Thank you, Prof. Thank you, Prof.
from microbiology. My background is microbiology. So my question is around bacteria. As you mentioned that one of the factors in pathogenesis of diabetes is inflammation. Especially, researchers said that it's called low-grade inflammation. And low-grade inflammation, the one factor that causes low-grade inflammation is the transmissible viruses, the imbalance of the gut microbial composition. So several researchers said that the regulation or the restoration of normal gut microbial composition is one factor that can reduce the event of low-grade inflammation. And they said the use of the functional food like probiotics and other functional food can be used to restore the normal gut microbial composition. What is your opinion of this non-pharmacological modality in the treatment of diabetes? Or in Japan, is there any consideration to use this modality as maybe as a complementary or adjunctive therapy besides the pharmacological therapy for that? Thank you.
Yes, that is a very important issue too. And the other than synthetic drugs, like the nutritional therapy is the one very important. And the other issue is the intestinal microbial flora that influence a lot of diseases, including diabetes. It is not very certain at this moment whether the modifying microbial flora in intestine that can help diabetes treatment, but there is very good possibility over there. And the other herbal drugs and sometimes it is very difficult to prove it's really effective or not, but also the possibilities.
Thank you.
Yeah, I think likely also that the gut microbiota also can induce the GLP-1 in the intestines. Yes. Yeah. Beside talking about the oxidative stress, because they're related to the differentiation of the composition of the gut microbiota. Okay. Yeah. Baik. Tadi di sana siapa? Oke, mahasiswa silahkan.
Good morning. Tanizawa, very grateful that I can attend this general lecture. And your lecture regarding this current diabetes research is really insightful for me. So, from your explanation regarding the basic mechanism of diabetes, especially in the beta cell decrease in number, regarding the differentiation and the transdifferentiation of beta cell. So I found that the basic of this problem is not only because the drugs that we currently develop is not effective, but also about the stress oxidative that keep happening in diabetic patients. So in diabetes, as you mentioned before, there is a glucose toxicity that leads to oxidative stress and continuously leads to the differentiation and differentiation of beta cell and leads to insulin deficiency. So, is there any other treatment that our therapy that currently studied regarding this problems, specifically target the beta cell differentiation and transdifferentiation because of the oxidative stress in diabetic patient? And is there any other treatment or therapy that currently developed, such as stem cell therapy, for example? How far it have been studied in Japan, especially? Thank you very much.
Okay. Okay, the differentiation and transdifferentiation problems, it is proved that GLP-1 receptor agonists reduce the cellular stress in some part and may be partly effective for the differentiation or transdifferentiations. We are finding very interesting molecules involved in cellular stress. And when we knock out that molecules in addition to the WFS1, that animal would not develop diabetes at all. So some kinds of drugs acting on that molecule is very promising, but that is a very early stage of our basic investigations. I hope we can tell you the candidate of the drugs maybe in near futures. And the IPS or ESL replacement therapy, that is very important issue too. But that cannot solve the type 2 diabetes, because type 2 diabetes pathophysiology is very complicated. Combination of insulin deficiency and insulin resistance. But for the type 1 patients, the problem is the loss of beta cells. This is a lot promise of the replacing by the artificial beta cells from the iPS cells or ES cells. The research is already ongoing, and there is a method developed already to differentiate iPS cells to beta cells. That will be in the clinic in several years later. Thank you very much.
Thank you, Prof.
Sudah jelas ya. Iya, mungkin Prof. Sri.
Thank you, Prof. Swastika. Thank you, Prof. Tanizawa, for your presentation. It's very insightful for me, especially is one of your slides mentioned that infection is a predisposition for diabetes. I'm from microbiology department, so that is very interesting for me. What kind of infection? Is there acute infection or chronic infection, and how come it makes diabetic in this patient? Thank you.
Infections?
Infection.
Bacterial or viral infections.
Oh.
Okay. The viral infection involved a lot, the people says, for especially on the type 1 diabetes, that as a trigger of autoimmunity to the beta cells. But I'm not sure a lot of know about the involvement for the type 2 diabetes. But in general, the people with diabetes can suffer easier from infectious diseases and very less resistant to the infectious disease. But it is not related to the cause of the diabetes.
Thank you, Prof.
Yeah, I think in general that autoimmune disease might be almost contributed by beside the genetic and also the viral infections, not only in type 1 diabetes, but another autoimmune disease also. Yeah. Jadi memang virus salah satu mungkin inducernya. Jadi kerusakan yang memang dia potensial sudah ada genetik untuk kelainan diabetes, diantaranya diabetes tipe 1 memang. Ya, type 1 diabetes mungkin. Fine, any other questions? Yeah, I'm very interesting to know that when I'm studied in Japan in 92, I know that the concern of the diabetic scientists from Japan is always how the contribution of the insulin secretion failure especially in the Asian population In that time, I studied on the glucokinase gene in that time. And yeah, I know that it is related to Modi type. But until now, I quite agree with you that maybe Asian population a little bit different with the Caucasian ones, and then pancreatic or beta cell failure is maybe more dominant in Asian countries populations, and then also any evidence that incretin based therapy maybe show a little bit better in Asian population compared to the Caucasian. It is related, according to you, it is related to the improvement of beta cells, which beta cell to be a predominant failure in Asian population. What do you comment about that?
Yeah, of course, the investigation for the insulin resistance is very active in Japan too. But
Yes.
we believe that the Asian people, including Japanese, have weaker beta cells than the Caucasians. And so that many of the scientists, the diabetes scientists, is working very hard on the beta cell biologies, including myself. Yes.
Iya. Baik, mungkin ada pertanyaan lagi. Boleh kalau bahasa Indonesia nanti diterjemahkan. Tapi tidak diterjemahkan bahasa Jepang, saya juga tidak bisa. Ada lagi? Tidak? Kalau tidak nanti kita akhiri mungkin ya. Okay. Fine, no any question anymore from the audience. So once again, on behalf of the Udayana University and also personally, I express thank you very much and also appreciation for your contribution, for your sharing knowledge and experience, especially on research. And I hope not only stop until here, but I hope in the future we have a collaboration on research, especially on diabetes or other endocrine diseases. Okay, and then once again, thank you very much. Arigatou gozaimasu.
Yeah, thank you so much to paying attention to my talk, and I hope the more and more collaboration in diabetes field and medical field and other fields between the Yamaguchi University and the universities. Thank you very much again.
Thank you, Professor Yukio Tanizawa, MD, Ph.D. from Yamaguchi University, who has presented about very interesting material about recent advance in diabetes, clinical practice and research on general lecture this morning. And also thank you for the moderator, Professor Dr. Ketut Swastika, SPPD KMD from Udayana University. Thank you very much, Professor. And before we close, we have a little gift from Udayana University that represented by the Dean of Faculty of Medicine. Please can stand. It doesn't feel like time has passed so quickly that we have to reach the end of the event. Thank you for all the participants, professor, doctor, internists, resident, co-assistant, and all head department and staff who and invited guests who have taken the time to attend this general lecture this morning. Hopefully, the knowledge that have been presented can be useful and make us a wiser doctor. And hopefully, we can meet in another time. Last but not least, I have a little word. In learning, you will teach, and in teaching, you will learn. Thank you very much. So that's for me. If there is a mistake in words and action, both intentional and unintentional, I apologize profusely. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh. Shalom. Namo Buddhaya. Om